able to listen to the session subsequently. So I just want to let everybody know that. As I pointed out last week, if you have any suggestions at all, any ideas for making the session better, anything you'd like to see, please go ahead and click on the education link that you got with your invitation. Alternatively, you can email me at T as in Tom, Davis at sagisdx.com, or certainly feel free to call or text. My cell phone is 210-416-4815. So that being said, we'll go ahead and get started. Slide 1 is a shade biopsy, clearly an inflammatory process. And one can see that there is a superficial perivascular infiltrate with a decidedly lichenoid or band-like infiltrate obscuring the dermal epidermal junction. Not much in the way of an infiltrate deeper in the dermis. If we move to higher power, we can see that the cornified layer is thickened in most areas by compact orthokeratosis. Are zones of somewhat wedge-shaped hypergranulosis across the biopsy specimen. There is a band-like infiltrate of lymphocytes, which obscures the dermal epidermal junction. There are a few apoptotic or necrotic cells evident along the basal layer, circling one here with my pencil. The infiltrate is largely lymphocytic with a few melanophages. And I think a point that we made last week, anytime you see a lichenoid infiltrate obscuring the dermal epidermal junction, you're going to have a little vacuole. There also is kind of dissolution of the basal layer here. So these basilar keratinocytes have begun to keratize. So if you notice along the DEJ, which is kind of irregular with a sawtooth configuration, there are no real basaloid cells. And so this was, I threw this out as a pretty classic example of Lichen planus, which is our kind of our prototype, our classic example of an interface dermatitis of a lichenoid type with a superficial infiltrate. Things that you might consider in the differential, lichenoid drug eruption. Typically with the lichenoid drug eruption, there's more parakeratosis within the cornified layer. In addition, the granular layer is usually characterized by zones of hypogranulosis and sometimes hypergranulosis, but you don't get the real defined wedge-shaped hypergranulosis that you see in this particular specimen, in most cases of a lichenoid drug. In addition, the inflammatory infiltrate usually has lymphocytes, plasma cells, if you're lucky, maybe an occasional eosinophil. And at times you'll see clusters of necrotic keratinocytes evident along the dermal epidermal junction. Another item that enters into the differential is a benign lichenoid keratosis or lichen planus-like keratosis. There, in those biopsies, one typically sees parakeratosis rather than just compact orthokeratosis. And because most BLKs represent one stage in the devolution of a solar lentigo or seborrheic keratosis, over at the edge of the specimen, one can usually see remnants of a solar lentigo. All that being said, I've seen plenty of BLKs that look just like lichen planus, and I've been ready to sign up the case as lichen planus, and you look at the history, and it's comes in as papilloma just rule out basal. And rule out basal cell is a real common clinical history to guide you to the diagnosis of a We'll go ahead and move on to slide 2. Pretty small little biopsy here. Bisected. I'm going to go ahead and flip it so everybody is not standing on their head. And as we move to higher power, we see a strikingly, at first glance, psoriasiform dermatitis. There's very uniform epidermal hyperplasia. As was the case in the biopsy of psoriasis we saw last week, there's thinning of the suprapapillary plates. There's really no discernible granular layer in most areas. There are dilated and tortuous vessels in the papillary dermis, and in a few foci, there were even some neutrophils present between widened intercellular spaces. Looks a lot like psoriasis, and that's a feature that's very common in this condition. However, if you look at the edges, you can see an abrupt transition in the staining pattern of the epidermis. Notice at the edges, the keratinocytes are a lot darker in color with this abrupt transition. The epidermis in the center is characterized by glycogen-laden keratinocytes. So this is a condition in which there's a localized phosphorylase deficiency. This is a pale cell acanthoma. And this slide shows you that these lesions can mimic psoriasis in many respects. And indeed, if you've ever seen one of these lesions clinically, they're bright red, much like a flak of psoriasis would be. And this is believed to represent just a benign keratosis, like a seborrheic keratosis of localized phosphorylase deficiency. We'll go ahead and move on to slide 3. Both slide 2 and slide 3 underscore the fact that occasionally tinctorial or staining patterns or the appearance of the color in sections can be a real clue to a given diagnosis. Here we have a deep dermal subcutaneous nodule. It's a little bit of dermis here that I'm circling. Down in the fat, we have a very circumscribed nodule. And one can see that there are both areas that are devoid of nuclei with a very characteristic pink-orange or salmon color. And we'll come back to this because this is a real clue to this particular diagnosis. And then there is a population of more basaloid appearing cells out at the periphery of this lesion. And again, remember, we touched on this last week, when we say that the cell is basaloid, we mean that it has a high nuclear to cytoplasmic ratio. So what we're seeing here basically are a lot of nuclei. And if we zone in, we can see that this is a pretty germinative, mitotically active epithelium. You can see at the periphery numerous mitotic figures and even a few apoptotic cells. Looks kind of scary. But these cells are matrical cells, hair matrix, and they're undergoing abrupt transition. Here you can see a few retained nuclei, giving rise to centrally located shadow cells. So this is like a hair matrix giving rise to hair cortex. And these ghost cells, or shadow cells, are indicative of follicular differentiation, and specifically differentiation towards the inferior portion of the hair follicle. This pink, orange, or salmon color is virtually diagnostic of shadow cells. So anytime you see that color on scan, you know that there's evidence of follicular differentiation. Of course, we see that most common in pilomatricomas, but occasionally you can see matrical differentiation even within mixed tumors, which tend to be folliculo-apocrine or largely apocrine tumors. So salmon color, think shadow cells, think follicular differentiation. And this, of course, is an example of a pilomatricoma. This is a relatively early pilomatricoma in that we have plenty of basaloid cells, which are undergoing this abrupt transition to form shadow cells. As these lesions mature, all of the basaloid cells will ultimately keratinize. So a later stage pilomatricoma is going to have no basaloid cells, just shadow cells. And the shadow cells sometimes will begin to calcify. We're seeing a little bit of that up at the top of the tumor, where you can see these shadow cells becoming somewhat basophilic due to the deposition of calcium salts. And then furthermore, these calcified shadow cells can serve as a nidus for ossification within the stroma. So sometimes in a real old Pilomatricoma, all you'll see are calcified basoid cells and bone. So this is a lesion which changes over time. The other point that I'd like to make is Pilomatricomas, rather than thinking of them as follicular tumors, really you should think of them as a matrical cyst. If you think about the two other types of follicular cysts that we see, an infundibular cyst or EIC, that shows differentiation towards the infundibular portion of the hair follicle. So we get a cystic structure that's lined by stratified squamous epithelium that keratinizes with interposition of a granular layer and that contains keratin that has kind of that shredded wheat appearance. The second type of follicular cyst that we see is the isthmus catagen type. That resembles more the outer ridge sheath epithelium or the isthmic portion of the hair follicle. You get abrupt keratinization without interposition of a granular layer. And while it's lined by stratified squamous epithelium, the keratin centrally has that homogeneous appearance. Think of a Pilomatricoma as a matrical cyst. It begins as a cyst that's lined by this matrical epithelium that forms keratin that is like that of the hair cortex, in other words, shadow cells. So Pilomatricoma. Slide 4 was an incisional biopsy. And so, you know, if you looked at all pieces here, you could see that we had a partially sampled lesion. And clearly, I think even at scan, you can see that this lesion is characterized by nested aggregates of cells. This lesion is a little bit asymmetric with regards to the inflammatory infiltrate. So this inflammatory infiltrate in the dermis is a little more dense in one half of the specimen than the other. And as we move to higher power, you begin to see that these nests that are present along the dermal epidermal junction are not equidistant from one another. They vary somewhat in size and shape. In a few areas, there is a predominance of solitary melanocytes along the dermal epidermal junction, some becoming confluent. There is, in some areas, upward scatter of melanocytes as solitary units and nests into the overlying epidermis. And then cytologically, if you look at these cells are really atypical. Marked nuclear pleomorphism. The nuclei are variable in size and shape. Some of them are quite hyperchromatic. And look at the cytoplasm of these melanocytes. It contains this kind of dusty gray-brown cytoplasm. To my mind, this always reminds me of the smoking lounge at an airport. You know, you go by these glass encased rooms and they're just filled with kind of this smoke. And anytime I see melanocytes with kind of smoky cytoplasm, I always get concerned about the possibility of melanoma. And this is indeed a pretty classic superficial spreading melanoma. Again, fairly broad, asymmetric. The nests are variable in size and shape and not equidistant from one another. There's, in areas, quite a bit of pagetoid spread or scattered melanocytes as solitary units and nests into the overlying epidermis, and there's clear-cut cytologic atypia. So hopefully this didn't give anybody too much trouble, and I can virtually guarantee you you're going to get a melanoma of some form on your Okay, let's go ahead and move on to slide 5. I'm going to flip the slide again. And here we have a pretty robust punch biopsy from the trunk. And, you know, first blush, it looks like a psoriasiform lichenoid dermatitis. One can see a little bit of scale crust in the stratum corneum. The epidermis is hyperplastic, and there's kind of a dense band-like infiltrate, which appears largely lymphocytic and which is focally obscuring the dermal epidermal junction. And generally, when you see a psoriasiform lichenoid dermatitis or infiltrate, three things that should come to mind in the differential right away are secondary syphilis, lichen striatus, and mycosis fungoides. Of course, with secondary syphilis, you'd like to see a little bit of a deeper infiltrate, maybe some pallor in the epidermis, and if you're lucky, as you are in 2/3 of the cases, plasma cells. With lichen striatus, you like to see kind of a heavy infiltrate around the eccrine coils. So the infiltrate will tend to track down around the eccrine coils. Well, let's go ahead and look here. As we move to higher power, one thing that you should really note is the papillary dermis is a little bit fibrotic here, meaning this is kind of a long-standing process. And we've got slight thickening of the collagen by, we got this coarse collagen, papillary dermis by coarse collagen and kind of haphazard array. In addition, as we start moving into higher power, we can see that some of these lymphocytes are actually pretty large and hyperchromatic with irregular nuclear contours. And some of these, although I've definitely seen more pronounced cases, are noted to extend into the epidermis and into follicular epithelium with really only a scant amount of spongiosis. Some of them are also noted to track along the dermal epidermal junction. A few of them are surrounded by halos. And again, many of the lymphocytes here in the epidermis are larger than those in the dermis. And this was an example, this is an example of pad stage mycosis fungoides. We just have too many hyperchromatic lymphocytes here in the epidermis for the degree of spongiosis. And of course, in a case like this, we go ahead and immunophenotype the infiltrate. Most cases of MS are characterized by a predominance of CD4 positive lymphocytes. Generally, they constitute 90 to 95% of the lymphocytes, with only about 5 to 10% being CD8 positive. But there are exceptions to that rule. A lot of times, too, you'll have loss of CD7 expression and then a gene rearrangement on TCR with both beta and gamma probes. So anyway, this is an example of mycosis fungoides. I think if they were to show you one on the board, they're probably going to give you one with even more pronounced epidermotropism than this. But psoriasiform lichenoid, think of MF, think of secondary syphilis, think of mycosis fungoides. 6 and 7, I thought we would discuss together because they illustrate a point that needs to, I think, be made. Let me go ahead and slightly tilt this slide. Here, again, we have a punch biopsy from the trunk. On scan, you can see there's just kind of a sparse superficial perivascular infiltrate. The action here is in the epidermis. And one can see even at scan quite a bit of periolate scale crust within the stratum corneum. And we have an intraepidermal vesicle. Now, when one is confronted or comes across an intraepidermal vesicle, 3 questions that you want to ask yourself are: 1, where in the epidermis is the vesicle forming? Is it, suprabasilar, is it in the spinous layer, is it subcorneal? Number 2, what's the nature of the inflammatory infiltrate, not only in the blister cavity, but also within the dermis? And then 3rd, and most important, how did the blister form? And when we look at mechanisms of intraepidermal blister formation, probably the most common one that we see is spongiosis or intercellular edema, where the cells separate from one another, fluid accumulates, and the clinical counterpart, of course, is a spongiotic or an eczematous dermatitis. But intraepidermal blisters, as we saw last week, can also form as a result of ballooning or intracellular edema in the setting of viral infections or nutritional deficiency disorders. You can get necrosis leading to intraepidermal vesicle formation, or, as is demonstrated here, acantholysis can lead to the formation of intraepidermal vesicles. And sometimes all of those mechanisms will be operative together. So here we have a nice demonstration of suprabasilar acantholysis, a suprabasilar split, acantholytic cells within the blister cavity. Now, in addition to acantholysis, what we have going on here is also dyskeratosis. The keratinocytes that have become acantholytic are beginning to undergo premature keratinization. Their cytoplasm's becoming bright pink, and the nuclei are becoming apoptotic. So what we have here is a reaction pattern that we term focal acantholytic dyskeratosis. So we've got this split in the epidermis containing acantholytic or rounded up cells, which are dyskeratotic. This is a reaction pattern that in and of itself is not diagnostic of any one given condition, although its presence is requisite for the diagnosis of certain conditions. So when you see FAD, the possibilities are Darier's disease, Grover's disease, a warty dyskeratoma, which is basically a cyst, a follicle, or a duct, which contains acantholytic and dyskeratotic cells. And unlike this particular example, warty dyskeratomas tend to be endophytic and circumscribed. One can also see focal acantholytic dyskeratosis in isolated keratosis, so-called acantholytic dyskeratomas. Those can also be multiple, so one can get acantholytic dyskeratomas. You can rarely see FAD in an epidermal nevus. Those patients are probably mosaic for Darier's disease. And then finally, you can see FAD, this change, as just an incidental pattern, just as a small little focus, either in an excisional biopsy basal cell or in a variety of inflammatory and neoplastic conditions. So when we see a broad focus of FAD like this, unless the lesion's clearly papillated like a seborrheic keratosis, our key differential is going to be Darier's and Grover's, because those are two conditions with pronounced acantholysis and dyskeratosis. I think it would be extremely unfair for someone to ask you to discriminate those two conditions, because you really need clinical history. Grover's can look like Hailey-Hailey, it can look like Darier's, it can look like anything. This happens to be a case of Darier's disease. And, Darier's disease is characterized by close set papules that become confluent and form plaques. And if you look here, it's almost like we have three adjacent discrete foci of suprabasilar acantholysis with dyskeratosis. So I'm sure this was taken from a plaque of Darier's, and we had three very close set papules. So this is an example of Darier's disease, but the differential would include Grover's. Slide 7, kind of related, was a punch biopsy from the trunk. Again, one can see an intraepidermal vesicle that is formed as the result of acantholysis. Here, the acantholysis is present above the basal layer, but it involves much of the thickness of the epidermis. And unlike that last example, there's no really significant or appreciable dyskeratosis involving the epidermis. There may be an occasional dyskeratotic cell, but if we go back to the slide that we just looked at, the dyskeratosis in this case of Darier's disease is much more pronounced than that seen in this case. The epidermis here is acanthotic, and this is an example of Hailey-Hailey disease, where we get the suprabasilar acantholysis in an acanthotic epidermis with overlying acantholysis involving much of the thickness of the epidermis, but no appreciable dyskeratosis. This gives you the so-called dilapidated brick wall. Another metaphor that I've heard used here is leaves falling off a tree. And these acantholytic keratinocytes do kind of look like a tree dropping leaves in fall. The thing to keep in mind is that while Hailey-Hailey and pemphigus, like Grover's and Darier's, have acantholysis. Hailey-Hailey and pemphigus do not have an appreciable amount of dyskeratosis. So if you see FAD, where you've got pronounced acantholysis and dyskeratosis, you can pretty much exclude pemphigus or Hailey-Hailey in the differential diagnosis. Slide 8, we're out of inflammatory land and into neoplastic land. And this is one of these tumors that once you've seen one, you'll automatically recognize it. This is a punch biopsy, partially sampled tumor, transected. And one can see these cord strands and nested aggregates of epithelial cells, which really do not have that much atypia. A little bit of nuclear pleomorphism, but certainly not a high mitotic rate. Some of these have a slightly cribiform or sieve-like pattern, net-like pattern that you can see here. And these are embedded within a copious myxoid and mucinous stroma, kind of islands in a sea of snot. And this is an example of a mucinous carcinoma. Now keep in mind that mucinous carcinomas, when they occur in the skin, can be primary and adnexal tumors, or they can be metastatic. So there are mucinous carcinomas that look like this in the breast, in the GI tract, occasionally in the GU tract. They can be metastatic to the skin and look just like this. Sometimes you can use P63 staining, and if you've got a mixed tumor with P63 staining, that can be more indicative of a primary cutaneous adnexal mucinous carcinoma. But the bottom line is, the patients need to be carefully questioned, thoroughly examined, and imaged to rule out a metastatic mucinous carcinoma. These tumors are probably closely related to another adnexal low-grade carcinoma that's been recently described, the so-called endocrine mucin-producing sweat gland carcinoma. And that's probably an earlier stage of this tumor. And those occur commonly on or around the eye. But this is a beautiful example of a mucinous carcinoma, such an easy pattern that it's frequently used on tests because there's nothing much that looks like it. Okay, moving on to slide 9. I'm going to flip it. And we had a dense nodular infiltrate in the deep dermis and largely in the subcutaneous tissue. Definitely had a nodular quality. And I think even on scan, you can see that there are aggregates of cells that are more basophilic, probably lymphoid aggregates. And then we also had large nodular aggregates of kind of pale or clear staining cells as well. And if we move to higher power, we can see that these clear staining cells have, clear, pale, kind of pink staining cytoplasm, uniform nuclei, and again, this abundant cytoplasm. And then within the cytoplasm of some of these cells, there were lymphocytes, an occasional plasma cell, kind of passing through the cytoplasm, so-called empyropoiesis. And then out in the periphery, we had these nodular aggregates of both lymphocytes here and lots and lots and lots of plasma cells. And this is a very, very characteristic histologic appearance that is extranodal Rosai-Dorfman disease. And the clear staining cells here are S100 positive, but CD1A and Langren negative. And so this, if they gave you this on boards, this would be kind of a hard slide. This is a disorder that's really kind of strange. No one knows exactly what triggers it. And the lesions are common on the head and neck. Most commonly, this presents with massive cervical lymphadenopathy and fever, but there are a small percentage of patients who will have extranodal disease, and an even smaller percentage who will have cutaneous involvement only. But what's characteristic, it's kind of a non-X or non-Langerhans cell form of histiocytosis. But almost all instances have aggregates of lymphocytes and plasma cells, and then these large nodular aggregates of clear staining cells with evidence of emperipoiesis. So Rosai-Dorfman disease. Slide 10. Slide 10 was a tough one. Very subtle. This is something that you probably do on an inpatient consult service. This is a punch biopsy. This was from distal extremity. One clue that we're dealing with distal extremity here is the fact that the dermis is relatively thin, and we've got a fair amount of subcutaneous tissue. And think about it, you know, when you biopsy more distal, you're going to get more fat than you would if you biopsy trunk or proximal extremity. If we look at this particular piece and move into higher power, we can see that there's quite a bit of epidermal necrosis here. And there is a vascularly cornified layer. So this is kind of an acute process, very, very paucely inflammatory. And when I see changes like this, you know, I begin to wonder, is there something going on with the vascular integrity that is necrosing the epidermis? But, you know, no evidence of a vasculitis here or a vasculopathy. However, you searched around and looked at the dermal subcutaneous tissue, we have a vessel here with a cholesterol cleft. And this is a cholesterol embolism. And very, very subtle. Sometimes, and frequently, you don't see much in the way of inflammatory infiltrate. Sometimes you'll see necrosis of the eccrine coil, because that's obviously very subject to anoxic influence. And then frequently you'll see subtle epidermal necrosis, a lot of times hemorrhage too, because the lesions can be procured. But this was an example of a cholesterol embolism. Very, very subtle, but I thought I'd put, you know, kind of an equal number of super easy and more difficult slides on the test. That tends to be what they do on the boards. You know, most slides fall in the middle. If they give you 2 super easy slides, they're probably going to give you 2 equally difficult. That's just good test writing. The next case, punch biopsy. Obviously fairly deep. There's a little bit of inflammation in their dermis, but you know, the compartment of the skin that is really trashed here is the fat. So we've got a panniculitis, and we all know when looking at panniculitis, we need to decide where the center of gravity is. Is it predominantly septal? Is it predominantly lobular? Well, you know, I think even people starting out can see that this is a rip-roaring lobular panniculitis. I mean, there is extensive necrosis of the fat lobules here. Hard to even recognize this as fat. Very basophilic looking, lots and lots of neutrophils here. And if we move in to this area, we can see characteristic ghost cells or necrotic adipocytes, many of which have undergone saponification. So we have these calcium salts or calcium soap deposited at the periphery of the necrotic adipocyte. This is a 4+ example of pancreatic panniculitis. And I would definitely be able to recognize pancreatic panniculitis. Again, it's extremely testable. Again, some of the characteristic pink ghost cells that are necrotic with evidence of calcium at the periphery, so-called saponified fat. And of course, this is because the amylase and lipase is just kind of totally necrosed the fat. Of course, we always tend to think of pancreatic fat necrosis with pancreatic cancer, but the most common cause, of course, of pancreatic panniculitis is chronic pancreatitis. And we'll go ahead and close out here with slide number 12. Slide number 12 was horse of a different color. And one can see a very deep punch biopsy. Obviously, there are kind of nodular accumulations of inflammatory cells here in the dermis. Very pink and acellular centrally, which usually indicates that there's quite a bit of degeneration of collagen and necrosis. Almost looks over in the top piece like there's a follicle that's ruptured or some type of squamous line channel. If we move to higher power, we begin to see that there's kind of a mixture of cells here. We've got lymphoid cells, we've got maybe a few newts, and then we've got a lot of clear staining cells, and present within the infiltrate, there are, if you start looking around, large numbers of yeast forms that are markedly variable in size and shape. Some are small, some of them, like this one that is circled up at the top, have really narrow-based buds, and most of them are surrounded by a clear space. And in some of the clear spaces, you almost have little yeast condos forming. And this is an example of Cryptococcosus. This is gelatinous crypto. And of course, if you did a Muci-Carmin stain here, you would demonstrate the capsule. These organisms will be PAS and GMS positive, and crypto also will stain with Fontana Masson. And when you do those stains, you see that these are quite variable in size and shape. Now, this is an example of gelatinous crypto. Crypto also has a granulomatous form, and the granulomatous form is a little more difficult to see the organisms, and the capsules tend to be small. So I think if they were to give you one on the board, you'd probably get a gelatinous crypto, and that's the form that tends to occur in immunocompromised individuals, like those with uncontrolled HIV who develop numerous molluscum-like lesions. So anyway, that's all I have. I'll go ahead and post the answers tomorrow. If you have any colleagues who couldn't attend today's session, I'll repeat it tomorrow. And again, we're recording the session as well too, so it will be available for review. And want to thank everybody for your attention. And again, if you have any feedback, please feel free to give it to us. Hope everybody has a great evening. Thank you.